Back to Farm Buddies. I hope you're all doing great. If you're preparing for your JNTU pharmacy examinations, then today's video is especially for you. In this video, we're going to revise one of the most important pharmacology topics, antifungal agents. This chapter is frequently asked in university examinations, pharmacist recruitment examinations, and many other competitive pharmacy exams. By the end of this video, you'll understand how antifungal drugs work, why they target fungal cells selectively, and how to remember every major drug class easily. So, without wasting any time, let's begin. Before we study the drugs, let's first understand what fungi actually are. Fungi are eukaryotic microorganisms. Unlike bacteria, fungi possess a true nucleus and membrane-bound organelles. This makes them much more similar to human cells. Because fungi resemble our own cells, developing medicines against them is much more difficult than developing antibiotics. Scientists therefore look for structures that are unique to fungi. And one such structure is ergosterol. Human cells contain cholesterol, whereas fungal cells contain ergosterol. This single difference is the reason why most antifungal drugs work. Remember this point carefully. It is one of the most commonly asked bits of questions in JNTU examinations. Now, fungal infections are classified into two major categories. The first category are superficial fungal infections. These involve the skin, hair, nails, oral cavity, and mucous membranes. Examples include ringworm, athlete's foot, oral candidiasis, and vaginal candidiasis. These infections are generally treated using topical antifungal agents. The second category are systemic fungal infections. These infections affect internal organs, such as the lungs, brain, bloodstream, and other deep tissues. Examples include aspergillosis, cryptococcosis, histoplasmosis, and invasive candidiasis. These infections can become life-threatening, especially in immunocompromised patients. Now, let's move to the classification. This is a very important 5-mark question for JNTU examinations. Antifungal drugs are classified into 6 major groups. Let's discuss each one. Poly-NS. The first class is poly-NS. Examples include amphotericin B, nistidine, and natamycin. Among these, amphotericin B is considered the gold standard drug for severe systemic fungal infections, whereas nistidine is mainly used for oral candidiasis and topical fungal infections. Azoles. The second class is azoles. This is the largest and most commonly prescribed group. Azoles are divided into 2 subgroups. The first subgroup are imidazoles. Examples include clotrimazole, miconazole, ketoconazole, and econazole. These are mainly used topically. The second subgroup is triazoles. Examples include fluconazole, itraconazole, voriconazole, posaconazole, and isovuconazole. These drugs are used for systemic fungal infections. Next, we have allylamines. Examples are terbinafine and naphthafine. These drugs are highly effective against dermatophytes. Therefore, they're commonly prescribed for ringworm, athlete's foot, and nail infections. The next class contains only one important drug, flucytosine. Remember this drug carefully. It is almost never used alone. Instead, it is combined with amphotericin B, especially in cryptococcal meningitis. Now let's discuss echinocandins. Examples include caspofungin, micafungin, and anidulafungin. These drugs are particularly effective against candida infections. Other antifungals. Finally, we have drugs like griseofulvin, cyclopirox, and amorolfine. Griseofulvin is especially useful against dermatophyte infections. Now, let's discuss the most important section of today's topic, the mechanism of action. Take a careful look at the diagram on your screen. Almost every university examination contains at least one question from this figure. So understand it carefully. Let's begin with poly-NS. The fungal cell membrane contains ergosterol. Amphotericin B binds directly to ergosterol. After binding, it creates tiny pores within the fungal membrane. Because of these pores, important intracellular contents begin to leak outside the cell. Gradually, the fungal cell loses its integrity and dies. Therefore, amphotericin B is considered a fungicidal drug. Water and ions leaking through membrane pores. Now, move to the next pathway. Normally, lanosterol is converted into ergosterol by an enzyme called 14-alpha-demethylase. This enzyme belongs to the cytochrome P450 family. Azoles inhibit this enzyme. Once the enzyme is blocked, ergosterol can no longer be synthesized. Without ergosterol, the fungal membrane becomes unstable. The fungus stops growing. This is why azoles are mainly fungistatic drugs. Now, look slightly above. Terbinafine acts even earlier in the ergosterol synthesis pathway. It inhibits squalene epoxidase. As a result, ergosterol decreases, while toxic squalene accumulates. The fungal membrane becomes defective. Eventually, the fungal cell dies. This makes terbinafine very effective against dermatophytes. Flucytosine works completely differently. It enters the fungal cell. Inside the fungus, it is converted into 5-fluorouracil. This active metabolite blocks DNA synthesis and RNA synthesis. As a result, the fungus cannot multiply. Because resistance develops rapidly, flucytosine should never be used alone. Remember this point for exams. Unlike other antifungal drugs, echinocandins do not target the cell membrane. Instead, they inhibit beta-1,3-D glucan synthase. This enzyme produces glucan, which forms the fungal cell wall. Without glucan, the wall becomes weak. Eventually, the fungal cell ruptures. Echinocandins are therefore excellent drugs against Candida species. Finally, griseofulvin. This drug binds to fungal microtubules. Microtubules are essential for mitosis. Once microtubules are disrupted, cell division stops. Therefore, griseofulvin is classified as a fungistatic drug. Let's revise everything in less than 1 minute. Poly-NS bind ergosterol. Azoles block ergosterol synthesis. Allylamines inhibit squalene epoxidase. Flucytosine blocks DNA and RNA synthesis. Echinocandins prevent fungal cell wall formation. And griseofulvin stops mitosis. Till now, we have learned about the classification of antifungal drugs and their mechanisms of action. Now we'll focus on the pharmacological profile of antifungal drugs, including pharmacokinetics, adverse effects, important drug interactions, contraindications, and clinical applications. Let's begin with pharmacokinetics, which explains how the body handles a drug after administration. We'll look at 4 key aspects: absorption, distribution, metabolism, and excretion, often remembered as ATME. First, amphotericin B. One important exam point is that amphotericin B is not absorbed orally. Therefore, it is administered intravenously for systemic fungal infections. Although an oral formulation exists, it acts locally in the gastrointestinal tract and is not useful for systemic disease. Next is nistidine. Nistidine is also not absorbed from the gastrointestinal tract. This property makes it ideal for treating oral candidiasis and intestinal fungal infections because the drug remains localized where it is needed. It is also widely available as topical creams, ointments, and suspensions. Now let's discuss the azoles. Most azoles have good oral bioavailability. Many members of this class undergo hepatic metabolism, so liver function should be monitored during prolonged therapy. Fluconazole deserves special attention because it penetrates the cerebrospinal fluid, making it useful in the treatment of cryptococcal meningitis. Terbinafine is well absorbed after oral administration. It accumulates in skin, hair, and nails, where dermatophytes commonly grow. This explains why terbinafine is one of the preferred oral drugs for onychomycosis, or fungal nail infections. Finally, flucytosine. This drug is excreted primarily through the kidneys. In patients with renal impairment, the dose must be adjusted to prevent toxicity. Now let's discuss the adverse effects of antifungal drugs. Understanding toxicity helps you answer both theory questions and clinical case scenarios. Let's start with amphotericin B. The easiest way to remember its toxicity is the famous mnemonic, amphoterrible. This drug can cause nephrotoxicity, fever, chills, infusion reactions, hypokalemia, hypomagnesemia. Because of its kidney toxicity, patients receiving amphotericin B require regular monitoring of renal function and electrolytes. Azoles. The most important adverse effect of azoles is hepatotoxicity. Patients receiving prolonged azole therapy should have periodic liver function tests. Ketoconazole has an additional endocrine effect because it inhibits steroid hormone synthesis. This may lead to gynecomastia, decreased libido, menstrual irregularities. Although these effects are less common today due to limited use of ketoconazole, they remain important for examinations. Terbinafine commonly causes the following: gastrointestinal discomfort, headache, skin rash, loss of taste, hepatotoxicity. Any persistent alteration in taste or symptoms of liver dysfunction should be reported promptly. Flucytosine may cause bone marrow suppression. This can result in anemia, leukopenia, thrombocytopenia. Regular complete blood counts are recommended during therapy. Echinocandins are generally well tolerated. However, some patients experience the following: fever, chills, histamine-mediated infusion reactions. These reactions are usually mild compared with amphotericin B. Griseofulvin may cause the following: headache, photosensitivity, hepatotoxicity. Patients should be advised to minimize excessive sun exposure while taking this medication. Drug interactions are especially important with azoles. Azoles inhibit cytochrome P450 enzymes. Because of this, they can increase the blood concentration of several medications, including warfarin, statins, cyclosporin, tacrolimus, certain oral hypoglycemic agents. When these drugs are used together, dose adjustments or careful monitoring may be required. Another important point is that ketoconazole requires an acidic environment for optimal absorption. Therefore, antacids and proton pump inhibitors can reduce its absorption and effectiveness. Let's review the major contraindications and precautions. Amphotericin B should be used cautiously in patients with pre-existing renal disease. Azoles require caution in individuals with liver dysfunction. Terbinafine is generally avoided in severe hepatic disease. Flucytosine should be used carefully in patients with bone marrow disorders because of its myelosuppressive effects. Always evaluate liver and kidney function before initiating prolonged antifungal therapy. Now let's connect each drug with its major clinical use. For oral candidiasis, the preferred drugs are nistidine and clotrimazole. For vaginal candidiasis, fluconazole is commonly prescribed. For dermatophyte infections, including ringworm and athlete's foot, terbinafine is highly effective. For onychomycosis, oral terbinafine is considered a first-line treatment because it accumulates in nails. For invasive candidiasis, echinocandins such as caspofungin are frequently used. For aspergillosis, voriconazole is the drug of choice. For cryptococcal meningitis, the standard induction therapy is amphotericin B plus flucytosine, followed by fluconazole for consolidation and maintenance. For severe, life-threatening systemic fungal infections, amphotericin B remains one of the most important antifungal agents. Before we conclude, let's revise a few important examination points. Remember these key facts. Heavy checkmark amphotericin B is not absorbed orally and is highly nephrotoxic. Heavy checkmark nistidine is not systemically absorbed and is used mainly for local fungal infections. Heavy checkmark fluconazole has excellent cerebrospinal fluid penetration. Heavy checkmark terbinafine accumulates in skin, hair, and nails. Heavy checkmark flucytosine is excreted by the kidneys and requires dose adjustment in renal impairment. Heavy checkmark azoles are associated with hepatic toxicity and significant CYP450-mediated drug interactions. If you remember these 6 points, you'll be well prepared for many pharmacology questions related to antifungal agents. Congratulations! You've successfully completed the Antifungal Agents revision series. Remember, understanding the mechanisms, not just memorizing drug names, will help you answer both theory questions and multiple choice questions with confidence. Take a short break, revise your notes once more, and trust your preparation. If you found this revision series helpful, please support Pharm Buddies by liking this video, sharing it with your classmates, and subscribing to the channel. Let us know in the comments which pharmacology topic you'd like us to cover next. Thank you for learning with us. This is Pharm Buddies, wishing you all the very best for your JNTU B Pharmacy examinations. Until next time, happy learning, and good luck. Graduation cap.